Perfect. Thank you for the introduction, Elena. So again, I'm Mark Miller. I'm one of the pediatric orthopedic surgeons here at Shriners in St. Louis, and I'm here the chief of surgery here in St. Louis. And I've got over the last couple of years, I've gotten to know the Twin Cities team really well. First, acting as the Midwest market physician lead, and that was then transitioned to a broader kind of Shriners Children's Medical Group role as the Central Region physician lead, which is in the Midwest market and the South market. And we've worked a lot in the last kind of couple of years of acting kind of as a system rather than separate sites. And so we've had a bi-monthly uh, Midwest market case conferences where Chicago, St. Louis, and Twin Cities orthopedic surgeons kind of present cases and discuss. We also kind of shared kind of patients across different sites, as well as kind of shared our own patient ideas. And I feel like I feel like I almost know the Dr. Sinha, Dr. Lang, and Dr. Vera as much as well as I do my own local partners here in St. Louis. And the impetus for why I want to discuss infantile Blount disease, we actually had a patient shared between their two sites that had been treated at Shriners Twin Cities for many years for infantile Blounts and has some residual deformity. And we had planned to come down to St. Louis. Dr. Sinha was going to join me. We would do a case together for a larger external fixture frame correction. Supposed to be weeks. The family actually wants to do it next year, but this is just impetus for doing this talk. Again, show that we we do kind of share these patients across our sites. So I have about 30 minutes of presentation. So they'll leave for a good 10 to 15 minutes of discussion at the end. So again, going for during the presentation, kind of send your either put your questions into the chat or send to Elena. We're going to answer along, and then we'll also at the end of the talk. So I have no conflicts, no disclosures. So what is Blount's disease? So Blount's disease is pathologic proximal tibia vera, or bow legs of the lower extremities, and it's present. That's diagnosed kind of in the early infantile period. So 1, 2, or 3 gets separated from adolescent Blounts, which is a later onset tibia varus deformity in the legs, which presents more in the adolescent period. So we're focusing today on infantile Blounts. So bowing of the legs is actually fairly common in kids. Majority of it is physiologic, some of it is not. And so our kind of question as orthopedic surgeons is which of these types is physiologic and will kind of resolve on its own versus which is pathologic, which usually means they'll get worse with time. So to start out with, we kind of think about how our body develops. So during from birth until up about 18 months, most kids are bow leg. 10 to 15 degrees of varus is typical. It's usually maximal around kind of when they first start to walk, around 9 to 10 months. And so having bow legs initially at that time is a part of normal part of development. Now, certainly there's some that are outside of what this just looks more bowing than not. Those kids that, when they're 9, 10 months, we will get an x-ray if we think that that's outside of our typical expected range for bowing. And then around age 18 months, that tend to straighten to neutral. So if you have we can even diagnose physiologic bowing is greater than 10 degrees after 18 months. But even physiologic bowing, if it's part of kind of natural development, after 18, 20 months should be getting better with each of our x-rays if we're following them radiographically. Whereas a pathologic bowing condition would get worse after age 18 months. Again, most kids are going to be fairly straight by 18 months. Then they go the opposite direction. So 2, 3, 4, kind of maximum 3 years, they become physiologic knock knees or valgus or kind of more outward, so more inward bowing the knees versus a bowing is more outward bowing of the knees. So typically consider physiologic knock knees of 10, 12 degrees of valgus. And then by 7 years, most kids should be relatively straight. Certainly if there's concerns for valgus at this age, we should definitely refer to an orthopedic surgeon for evaluation of this more pathologic valgus. Again, not going to talk about this talk, but 7 degrees, if you're not straight for sure, should see an orthopedic surgeon. And we'll talk a little about what kids, when you see in your kind of general pediatric clinic, like what is pathologic, what is not. than what you see in orthopedic surgery. So in young children, the differential is most of the bowing that you see in children is going to be physiologic bowing. Now, physiologic bowing affects both the femur and the tibia, again, it should get better on its own after age 18 to 20 months. Few of those will make the diagnosis of infantile Blount's disease. And so I'll show a little bit, there's some radiographic parameters that we can kind of decide, hey, this is infantile Blount's and going to be pathologic. I'll share that in just a bit. More uncommonly, if the bowing is more than we would expect for their age, certainly X-ray can be very helpful for us again, to get our kind of metapsodiaphysis angle. Again, I'll show that, but also look at the physis. Is there a metabolic condition, whether it be X-linked hypophosphatemia rickets or nutritional rickets or other kind of metabolic conditions that can create bowing, or are there skeletal dysplasia, relatively rare. Sometimes be other genetic conditions associated, but sometimes the first time we diagnose that is based off of the radiographic appearance of the bones around the joints or their growth plates. Again, infantile Blount's, metabolic, bone disease, and skeletal dysplasia are pathologic, but physiologic bowing is physiologic. So again, here's a patient with X-linked hypophosphatemia rickets. On our X-ray here, we have a standing EP of both lower extremities, demonstrating both the femur and the tibia are involved, kind of widened physes, kind of speckled appearance around the physis, consistent with more metabolic bone condition. Again, we're not going to talk about that here, but there's something that is part of our differential when we see a kid with excessive bowing. So a little bit of first patient that we kind of have here. This is referred by a pediatrician. It's a 20-month-old male, early walker, around 10 months of age. And a lot of the physiologic bowers probably will be early walkers. They don't necessarily have to be. On the larger side, so both 90th percentile, both of height and weight, otherwise healthy. And dad had bowing and wore braces. That's part of our history. The question is, what do we do? If I feel that the patient's bowing outside of what I would expect, I do get a standing AP X-ray of both lower extremities. Now, that being said, most of the patients that are referred to me for bowing, I will get an X-ray, because if someone's concerned, I'd be concerned as well. And so first thing that we do when we're examining these X-rays is we do a examination of their mechanical axis. And so that's a line drawn from the center of the femoral head down to the center of the ankle, and look at where that relative to the knee. So if that line intersects the knee joint on the medial side or inside the knee joint, that is varus. If it intersects in the middle of the joint, and that's neutral. And if it intersects on the outside, towards the outside of the knee joint, that would be valgus or knock. So this is varus alignment. Also looking at the femur and the tibia, also have some bowing both femur and tibia. So I think maybe this is more physiologic, whereas Blount's disease is pathologic, bowing at just the tibia alone. Next, I'll show in a couple more pages again with our metapsodiaphysis angle. This is just an example of what I draw. I'll draw a line down the lateral cortex of the tibia versus a line along the physis, and as well as along the beak there. And those angles here will show what our metapsodiaphysis angle is. Again, we'll show under 10 degrees for sure is physiologic. Over 16 is Blount's. 12, there's been a fair number of these that we see will actually be indeterminate. They're between kind of 10 and 16. So on the left side, I think this is kind of more physiologic. 12, indeterminate. And the indeterminates almost always tend to be physiologic, but not always. But I'll show a little bit on a couple more slides on that. So we thought this was more physiologic, but indeterminate. So we decided to observe. And so we got an X-ray again 8 months later. Now with mechanical axis line is improving. So again, if Blount's disease would get worse after 18 months, so this is improving. So more thought that this is physiologic. And so we would continue to observe there. You can see kind of the difference in that mechanical axis alignment. Okay. 28 months. So, if we do make the diagnosis of Blount's disease, so pathologic proximal tibia varus in kind of the toddler range, sometimes we will do Blount's bracing. Now, for me, it's going to be hard to do that under age 18 months, really under age 2, because the leg has to be long enough to fit the brace. So a Blount's brace is a unloader brace that kind of unloads the medial physis and kind of helps compress the lateral physis. Typically these are more the milder infantile Blounts, between 18 months and 3 years. In my experience, Blount's bracing only works for unilateral and these younger children, the toddler age. Blount's bracing, in my experience, doesn't work after age 3. And then we look at kind of our Drennen's angle. That's the metaphyseal diaphyseal angle. Between 16 and 24 degrees is what I usually use. If they're more than 24 degrees, I probably will not treat them with the brace. Don't think it would work. There's already too much kind of force on the physis. In general, it takes 6 to 12 months for correction. And so these are braces that are worn during walking. So as they're awake and weight bearing, help unloading the medial physis, the lateral physis, encouraging the medial physis to grow. So here's a patient, 28-month-old female, history of bowing, parents noticed since birth, no pain. So again, differential is going to be is this physiologic bowing? Is it pathologic bowing, whether it be Blount's, metabolic bone disease, or skeletal dysplasia? It's just a little review of walking. Sometimes we'll look at for a varus thrust. So that's as they're walking, where they get collapse of the medial joint line and open up into more varus as they're walking, which is there's some kind of play. They also kids with both physiologic bowing as well as Blount's disease tend to have more in-towing. So proximal tibia, not proximal, but tibial interrotation. And so, but both of these, as physiologic gets better, the internal tibial torsion will also get better. Whereas Blount's disease actually will, if it does get better with bracing, the internal tibial torsion will correct. So here's their X-ray. So again, has a mild lateral thrust, mild varus thrust, no pain. So certainly more bowing than we expect. So first you draw the mechanical axis line, center of the femoral head to center of the ankle. Left is a little more involved than the right, which fits our clinical exam. We do that kind of Drennen's angle. Also, there's maybe some changes here in the medial physis, a little more beaking. Here we draw that in the lateral cortex. Here we have 22 degrees. So we think this is most likely Blount's disease because that metaphyseal diaphyseal angle is 22 degrees. So again, here we draw these angles down this lateral line versus at 90 degrees. That angle there pretends if it's less than 10 degrees, we know for sure that it's physiologic bowing. That's based off of studies from the 1990s. If it's 11 to 16, and most of the patients that I see for evaluation for this at this kind of 18, 24, 30-month range, actually end up being in the gray area. So we don't know yet. What that means, we have to continue to follow. And if they're 16 degrees, they're likely Blount's. Now, if this patient with a 22-degree metaphyseal diaphyseal angle I saw at age 28 months, and unilaterally, I would actually treat with Blount's bracing. My experience, bilateral bracing doesn't work because the brace just kind of get interrupted. It's hard to also walk with braces on both sides. So stop not walking. These patients parents as appropriately give up on bilateral bracing. So that we'll talk more about kind of treatment for this 22 degrees, but it would not be Blount's bracing for this patient. So again, this is Dr. Schenecker, one of my partners. Again, I appreciate Dr. Schenecker, Dr. Gordon, my senior partners who shared some of their slides, some of their cases. So again, draw up the lateral cortex, perpendicular line, and then beak to beak, your tibial metaphysis. That angle there is that metaphyseal diaphyseal angle of Drennen. Okay, Drennen's angle. Okay, so focal any long bone. So again, less than 10%, less than 10 degrees, greater than 95% probability that diagnosis physiologic bowing. So we'll get better with time after 18, 20 months. It's greater than 16 degrees, greater than 95% probability that is Blount's disease. So we'll get pathologic proximal tibia varus or bow legs of the tibia. Okay. So again, for physiologic bowing, most resolve, and treatment is not required as an infant, just observation. And, there's probably some kids that may have actually been physiologic that I treated with bracing, but again, most of the kids I treat with bracing, there's going to be just the tib involvement, so pathologic Blount's disease. But so I, in general, don't see a role for Blount's bracing in physiologic bowing. Although I have done it on a small handful of times, not necessarily indicated. So here's a patient who had physiologic bowing and had bowing both 15 degrees of bowing in the femur, 11 degrees of bowing in the tibia. Again, physiologic bowing involves both the femur and the tibia, whereas Blount's really only affects the tibia. And the femur in Blount's can be either neutral, actually sometimes they're valgus or knock-kneed at the femur, as the body's way to compensate, to try to bring the mechanical axis alignment more in line with the body. This is patient kind of been around 2 + 3 months. However, by age 3 and then age 5, they had resolved. Again, almost all resolved with treatment not required. Okay. Again, whereas Blount's disease, tibia vera progresses often with severe deformity. And so how we kind of classify our infantile Blount's is based on the Langenskjöld classification. So again, there are certain races where Blount's is more common. Actually, probably the highest percentage is actually in the Scandinavian population. So a lot of the early papers are from Norway and Sweden. Langenskjöld was a Scandinavian surgeon that had this classification, whereas grade 1 to 6. So 1 is early, and it's only small change on the medial physis. Grade 2, there start to be more change in medial physis, more widening. The growth plate is getting sicker. By stage 3, we're starting to have some sick medial physis. It's just not working as well. And in stage 4, you start to see also deformity of the proximal tibia, almost the pagoda shape where it starts to angle, which causes more instability and more pain. And the goal of treatment is to see them and get them before they turn to stage 4. Because once it gets stage 4, it's often irreversible, and then you start to get a medial bar, and then the physis basically no longer is functional at that stage. Although we do sometimes do bar resections if they're earlier, Langenskjöld 3 or 4 with a bar, we will sometimes do a bar resection to help encourage the physis to grow. So how do we kind of reverse that? So again, decreasing severity. So back to our 28-month-old bilateral with a metastatic F angle 22 degrees. So our initial treatment at that age is going to be hemipipsedesis. So what hemipipsedesis is, partial temporary closure of physis. So pipsedesis meaning the closure, hemi being partial. And so that is a plate along one part of the physis and screw in the metaphysis and the epiphysis. As you can see here, again, these are smaller kids. So these are the smallest plates we have. They look pretty enormous in these younger kids. And the way that hemipipsedesis works is you tension the one side physis. So for bow-leggedness, we put the plate in on the lateral side so that temporary stunts growth on the lateral side, allow the medial physis, or inside part of the physis, to grow to align. Whereas for valgus, if you think it's pathologic knock-knees or pathologic valgus, we'll put those plates on the medial side of either the femur and the tibia and put screws on the metaphysis and the epiphysis. And what will happen over time, as you start to correct, you'll get more differential growth medially, laterally, so the screws will actually start to diverge. We want to see screw divergence. And so for bilateral Blounts, I with early age, I will do this treatment for almost all of these kids. And try to get this early as we can. Probably the youngest I've done is about kind of 28 months, 30 months. Most kids we've been following. After about age 3, after 4, they start to get more Langenskjöld 3. The plates have less effect. So these are trying to get to these earlier. And again, from the size of the patient, in my hands, under age 2, they're just too small. And sometimes we don't even know if they're physiologically wearing Blounts yet. But 28, 30 months, 36 months is kind of the sweet spot for doing this. So here's an example We're now two months post-op, trying to start to have some early signs of correction. And then here is about 24 months post-op, again showing on both sides we had correction. So you can see here the screws are diverging, which shows we're doing correction. And so then we kind of took these plates out, and depending on the health of the physis, if we can get these early enough, and we get certainly before Langenschuld 4, if we can start to get this corrected, sometimes this is the only treatment. Again, for all of these kids, I do follow till skeletal maturity to make sure they don't recur. But if we can get that to kind of maintain the health of the physis, because what happens after you get so much bowing of the leg, you get compression of the medial physis. Sometimes those effects on that medial physis are irreversible. So again, the goal to treat infantile Blounts before Langenschuld 4, due to the physeal sickness as well as the joint line deformity, which does not remodel. So again, Langenschuld 4. Okay. So the natural history of Blounts is to Langenschuld 6, where you get complete medial physis block. You get medial condyle depression, really high angle of the physis, which makes of the joint line, which makes the knee unstable. You also get leg length difference for unilateral Blounts with this. And so this can be a very devastating kind of condition. Now, again, when they get to Langenschuld 6, there are things that we can do to treat that, but there are less invasive things that we can do before then. So again, here's a Langenschuld 6 with almost 80 degrees of deformity. So here's a patient, 12-year-old from Belize, long history of bowing, had some surgery in the past in Belize, complains of bilateral knee pain, deformity. This is a case where they had put plates actually on the wrong bone. They put it in the femur side. The femur actually was probably infantile skin, not typically in varus. So they actually created iatrogenic valgus deformity in the femurs because they cut the plates on the tibia, on the femur rather than tibia. So this we have both now iatrogenic deformities in the femur as well as a Langenschuld 6 kind of basically now closed physis, significant deformity, really significant lateral thrust as the knee joint is unstable because the condyles no longer fit. They no longer match, and there's a lot of varus valgus instability. So again, significant zone 3 varus on both sides. So there's something that we can we kind of measure out the angles. And we have valgus now on both of the distal femurs and severe varus. And this is the medial proximal tibia angle and the lateral distal femur angle. We want these to be around 85 to 90 degrees. And you have that in the femur, lower numbers is valgus, in the tibia, lower numbers is varus. And then the tibia is pretty significant deformity. Again, sometimes on the lateral view, you'll see procurvatum. So at apex anterior angulation on the lateral view. So one thing we can try when they have before we do any other correction, we need to stabilize the joint. And so what we'll do is something called a medial plateau elevation. And so that's an intra-articular osteotomy, hinge at the joint. And here's just an elevate. Here's just a demonstration of that, where we can make a cut in the articular surface, and so that you have a stable joint. You can't really you don't want to correct the overall alignment until you correct that joint line, because you'll create even more problems of an unstable joint, even though the mechanical alignment is more normal. So you have to correct this first if you have this severe deformity. So here's kind of a schematic. What we do, so you can see here also when you get that pagoda shaped angulation, you get lateral translation of that proximal tibia relative to the femur. So again, that pagoda, you get decreased weight-bearing area, lateral translation of the tibia, and an unstable knee. A lot of pain from this. So here's an example. This is a 12-year-old went to the OR for plateau elevation. So we kind of protect the anterior approach, we kind of protect the vessels posteriorly with the retractor. We place a hinge where we want to hinge our osteotomy, make multiple drill passes. Here, there's the anterior posterior drill passes here. Then we connect those with a laminar, with the osteotome. Then we connect. Then use a laminar spreader. Try to keep the hinge intact here at the articular surface, at the cartilaginous surface. we kind of carefully jack it up. And what we'll do is I kind of use the laminar spreader to open up until you start to see the knee joint stabilize, which means that the proximal tibia start to translate medially for this plateau elevation. There we go. Now we're there. We'll then have that correction. There we stabilize. And so then we'll kind of fixation kind of with screws, and then we'll do another screw, and then we'll usually do a little plate, sometimes a plate. So here's this patient after you did the plateau elevations, about 10, and then to do the rest of the correction for these more severe deformities, we'll use circular external fixators, which is outside the scope of this talk, but this is a patient that we did to tibial osteotomies. Now, when I do an external fixator correction of Blounts, because their LCL or lateral collateral ligament is stretched out, I will not do a fibula osteotomy and actually pull the fibula down, tightening the LCL. And that will help tighten the LCL, help stabilize the knee joint. Also, we had to correct the femurs because they had iatrogenic valgus deformities in tibias. And so we kind of did slow frame corrections. And here, after you remove the frame, they now have neutral mechanical alignment and actually has a stable knee and was doing quite well because of this. And this is that patient kind of 1 month after fixator removal. Okay, here's just our angles, showing that now our angles between 85 to 90 degrees. And now our gait significantly improved, no longer having a lateral thrust. Okay. Now with the case, we have starting to have ligament called 4, starting to have a early growth arrest. This is a before growth arrest. So when they get the ligament called 4, a 3 to 4, the A plates will no longer work. So someone will do a acute osteotomy. And so you can this is the patient we did a kind of a bar. We thought there was a medial physeal bar, so we'll do a physiolysis. So we'll do we'll use a burr to burr out the bone on the medial physis. We'll pack that with cranioplast, which is basically methyl methacrylate without barium that does not have the high temperatures that are more typical. Orthopedic bone cement, our neurosurgeons use this, and then correct with an osteotomy with kind of K-wires. Here's that patient. So we can also do a acute correction. So against this patient's going to be hit ligament called 3 to 4. So we'll do the goal of this more acute corrections are going to be to shift the mechanical elastic lower extremity to unload that medial physis. So we'll do an acute correction with the saw, fixed with K-wires. This is at a younger age. And this is kind of example showing that we can then correct that mechanical alignment to neutral in these younger kids. Well, once kids get older, we can't do this as well acutely, and we'll do that gradual correction with a fixator. So here's the same patient after correction at 3 years old, who maintained their correction by age 12. And I have kind of one last case. I want to present this a patient of mine from island country of Barbados, who I first met almost 10 years ago in actually an island of St. Vincent, where to go to as an outreach mission with severe, almost probably the most severe infantile Blount's case I've seen, with almost 90-degree deformities in his tibia. His femur is actually relatively normal. So I had done prior to this, a year previously, I did plateau elevations to normalize his articular joint line with removing our previous plate. There's still one screw that's present. And so we came to the United States for our frame correction. There's a little more complex frames because it's actually our computer programs that do to these external fixtures. There was no actual solution to this. So I had to kind of correct in stages, correct both. It was 80-degree correction both sides. You have 40 degrees of first correction stage, and then another 40 degrees in the second stage. So here's kind of our first, and then frames, and we keep correcting over the course of 3 months in the United States for almost 6 months. Now, depending on culturally in Barbados, if your legs are deformed, you actually can't go to school. So this is now a 12-year-old, 10, 12-year-old, never been to school. And here he is with our frames on after correction. And here he is in the middle is after we had taken off his frames. This is after being almost a year here in the United States. Was able to go back home to Barbados and actually start school for the first time. And also while he was here, he actually kind of caught up a lot in his language and his math while he was here in the United States. Was able to kind of almost, I think it was a couple grades behind moving back to Barbados. But the cool thing is that about 2 years later, that mom had sent me a picture of him with a big smile on his face from his soccer team. He joined and made their middle school soccer team. So something we've never been able to even do before correction was also first be able to go to school, but also be able to join a sports team and did well. So we really can have a positive impact on these patients. And so we've actually, as we've gone now more to the Eastern Caribbean, we're now seeing these kids earlier, having connection with their pediatricians, getting those referrals and earlier for kind of for bow-leggedness and doing our 8-plate hemophysedesis on those kind of age 2 and 3-year-olds. And so we're actually seeing less of the late deformity, sling and scroll 5 or 6, 4, 5, and 6. And so I feel like we're almost making an impact, bigger impact by catching this early. So definitely want to now open up for questions, and I'll leave kind of this referral slide. So just a little bit on referral. So for a pediatrician or other even orthopedic surgeon referral, so how much bowing is too much? I would say certainly if there's familial concern, totally agree just to send to orthopedics. Happy to see all those, even though we know it's more physiologic. Or if, hey, in your experience, this is more bowing in a 8, 10, 12, 18-month-old than you would think, please send it to us. Happy to evaluate in our Twin Cities office. We'll almost always, for these referrals, we'll get an x-ray, get a standing AP of both lower extremities. We'll measure our metapsodiaphyseal angle adrenin, and then we'll talk about treatment. And again, sometimes I'll be the surgeons, Dr. Sinha and Dr. Ver and Dr. Lang, will communicate with me a lot of these kind of more complex patients who need later reconstructions that sometimes we'll bring down here, and I'll do it with their surgeons down here in St. Louis. But a lot of these kind of smaller procedures are sort of corrective osteotomies. 8-plates, our Twin Cities team does in Blount's bracing. Our Twin Cities team does a phenomenal job. So here's kind of our phone, fax, and email and kind of intake. So I'm going to maybe I will go out of presenter mode. And we'll maybe open it up for, I think we have about 10 minutes for questions. Marcella.
Good morning, Dr. Miller. Thank you very much for your wonderful presentation.
Thank you. Good morning.
Good morning. That's it. No questions. Thank you.
Oh, okay.
Thank you, Dr. Miller. This is Ann Hoffman. I'm from the Twin Cities PT, and I'm just checking on the kids that had that severe angle, the older kids. Can that be non-painful, or is it oftentimes painful?
So I would say that if the kids have no instability, whether they have a normal kind of alignment of their proximal tibia, sometimes those cannot be painful. But certainly all the kids who have kind of pagoda-shaped tibia angle where they have instability, those kids are almost always going to be painful. Now, with longer term, you have zone 3 varus, so your mechanical axis line is medial to the knee joint. Long term, for sure, those will have kind of early kind of joint line degeneration and will have pain. But some of those without kind of that joint deformity can be without pain. But with instability, in my experience, almost all of those kids will present pain.
Okay, thank you so very much. A great presentation.
No, thank you. Appreciate it. Thanks for joining us this morning. Elena, were there any kind of questions in the chat or anything kind of emailed to you?
I was just looking at the chat. I don't see any, but people can certainly still pop their questions in there. And I haven't received any emails, no.
Okay.
So we can hold on for just a minute or so, but if people don't have any questions, we can end just
And
a
maybe
minute.
I'll put is Jeff Bruce or anyone from Twin Cities Pops on the line? If so, do you guys have any thoughts on Blount's bracing that you guys do up in Twin Cities? Or maybe the physical therapist may have a thought on that.
I don't think Jeff Bruce is on. And to be honest with you, I have not seen that in the early bracing, but I've only been back at Shriners here since last September, so it might be just my exposure to it. But I am following one of the older kiddos that's headed your way next year, and so this has given me great insight with helping her to prepare for her treatment also. So thank you.
Sure, and I know Tracy Brzelski, one of our physical therapists, on the line here for St. Louis, and we'll actually have her after we do that kind of frame correction for that patient. We'll want to connect you with our physical therapist, because there's our protocols that we have when the patients are in the frame. Because with the frame correction, the physical therapists have a huge role in that treatment after surgery. So thank you for kind of working with her, and I look forward to working with you next year when the family's ready for surgery.
Yeah, fantastic. I worked with the frames when I was at Shriners the first time with the limb lengthening. So I'm familiar with working with the frames, but not necessarily for this intervention. So this is helpful. Thank you.
Awesome. All right. I guess if there's no other questions, we'll give you those 5 minutes back.
Great. Dr. Miller, thank you so much. That was a great presentation, very informative. And again, we really, really appreciate you joining us this morning.
Awesome. Thanks, everyone.
Thanks. See you next month, everybody.